So the next speaker is another old friend of the CPFRC, Roger Fillingim. Roger is a pain psychologist that's done a lot of really seminal work in the pain field over the course of his career. He's looked at ethnic and racial differences, sex differences in pain perception, and today he's going to be talking specifically about race and ethnic group differences in pain. Roger?
Thank you, Dan. And can you hear me okay there? Yes. I wanted to talk about biopsychosocial contributions to racial and ethnic group differences in pain. Let's see here. There we go. And just to get started, have some definitions. Race and ethnicity are often used interchangeably. While they are related, they're not interchangeable constructs. And so I'll let you take a look at the definitions here, but the key point is that both race and ethnicity are proxies for a complex array of predominantly social and environmental factors that can substantively impact human health, right? So as we're talking about racial and ethnic group differences in pain today, we'll keep in mind that it's not because of someone's race or ethnicity that they may have more or less pain. It's because of things that race and ethnicity happen to be correlated with, predominantly in the US, is the data I'll share with you. And you could see from those definitions that race and ethnicity lend themselves to being understood in the context of the biopsychosocial model of pain. I've told people before that I'm evolving from a psychologist to a psychosocialist. So I'd like us to make sure we keep social in the biopsychosocial model. So we'll hit on that a little bit more as we go along. And so let's talk about some of what we know about racial and ethnic group differences in pain. First, from an epidemiological perspective. So this is work that Anna Zajakova and Hannah Grohl-Prokopchik have done. This was from the National Health Interview Survey. And Anna looked at several different definitions of pain that you can see here that can be extracted from this large nationally representative database. You can simply look at whether somebody has persistent pain, for example, of 3 or 6 months duration. You can look at how widespread the pain is. Do they have any pain whatsoever, regardless of duration or severity? Or you can look at pain that's severe or pain that's high in impact. That is, it impacts daily functioning. It interferes with daily activities. And when you look across all of these different definitions of pain, pain prevalence was highest for Native American and multiracial adults, and was lowest for Asian Americans. And I should point out here that all of these analyses, adjusted for age, sex, year of interview, so on and so forth, and so these are adjusted analyses. And so the groups that have the most pain are Native American and multiracial individuals. When you look at the more common comparisons, which is non-Hispanic whites compared to either non-Hispanic Black African American individuals or to Hispanic individuals, if anything, the prevalence of pain is lower in these two minoritized groups than it is in non-Hispanic whites. When you start looking at the more severe definitions of pain, you start getting a hint that non-Hispanic Blacks may have slightly more prevalent severe pain, as defined here. This is shown a little bit more clearly in this analysis from the National Health Interview Survey, where on the left there you see the prevalence of any chronic pain, and there you can see that non-Hispanic whites had slightly higher prevalence than non-Hispanic Black and Hispanic adults. Whereas when you look at high-impact chronic pain, the two minoritized groups there have higher prevalence of that more severe pain phenotype. So this is consistent with the epidemiology of race and pain as it's been looked at in the United States. The condition, and this is any chronic pain, the condition that's probably been studied most frequently with regard to racial and ethnic differences is osteoarthritis. And in this particular meta-analysis, Ivan Avon, who was a graduate student with us several years ago, looked at race differences in pain severity among individuals who had knee osteoarthritis. And what we're showing here are the effect sizes for pain as measured by the WOMAC, pain as measured by other instruments, self-reports of function, and performance-based measures of function. And all of these indicate with sort of moderate effect sizes that non-Hispanic Black individuals are reporting higher pain and more disability and are performing more poorly on tests of function among individuals who have knee osteoarthritis. And so if there is more severe pain in certain racial and ethnic groups, it's worthwhile to start thinking about why that might be. And one of the frameworks for looking at health disparities has been put forward by the National Institute on Minority Health and Health Disparities, and you can see this incorporates a large number of levels of influence from the individual to the societal level and domains of influence, right? So all of these types of factors could influence people at the biological, behavioral, all the way up to the level of the healthcare system. So it gets quite complex when you're trying to disentangle the factors that might be contributing to disparities in a particular health outcome, in this instance, pain. I would argue that I, in particular, and we as a field, have been somewhat pathologically focused on the individual level of influence and maybe to the detriment of our understanding of some of these other levels of influence. And one level of influence that always comes up when you're talking about racial and ethnic differences, particularly in this country, are socioeconomic influences, because there are such vast socioeconomic disparities across race groups in this country. And what we showed here, Catherine Thompson, working with our data from the Upload study, looked at how socioeconomic status, self-reported socioeconomic status, might be associated with pain severity differently in non-Hispanic Black and non-Hispanic white adults. And what we see is that in non-Hispanic white adults, there's a pretty strong association such that non-Hispanic white adults below the poverty line consistently report worse pain and worse physical function than their counterparts that were above the poverty line, but we really didn't see an influence of socioeconomic status on pain in our non-Hispanic Black individuals. And then Burl Gooden, Edwin Aroki at UAB at that time did a similar analysis. This was perceived social status, so not socioeconomic status specifically, but your perceived social standing. And again, the effect or the association of perceived social status with pain interference, and this was in people with chronic low back pain, was significant among whites, but not among blacks. So we begin to see that certain factors, in this instance socioeconomic factors, may be differentially associated with pain outcomes in different racial and ethnic groups. Another outcome that we've been interested in, and this is work by Star Booker at the University of Florida, is movement-evoked pain, because this seems to be influenced sometimes by factors separate from what influences either retrospectively reported pain or ambient pain. And so this is movement-evoked pain measured during the course of performing several lower extremity activities in people with knee osteoarthritis, a balance task, a walking task, a chair stand task, and a leg strength task. And what Dr. Booker showed here is that our non-Hispanic Black individuals with knee osteoarthritis reported more movement-evoked pain even after controlling for several variables, including their ambient pain right before they were tested. So this movement evoked greater pain in our non-Hispanic Black individuals. And what's more, Dr. Booker showed that perceived stress was correlated with movement-evoked pain. More stress was associated with more movement-evoked pain in our non-Hispanic Black participants, but not in our non-Hispanic white individuals. So again, a sort of race-dependent association with pain here. And moving sort of toward the resilient side of things, we've talked about that some this morning. Dr. Emily Bartley looked at individuals with knee osteoarthritis, and this was in the same sample I've been talking to you about. Our non-Hispanic Black adults reported greater pain and disability than our non-Hispanic white adults. But Dr. Bartley also looked at resilience factors and found that higher resilience was protective against movement-evoked pain in our non-Hispanic Black sample, but not among our non-Hispanic whites. So we're finding here that some social and some psychological factors appear to differentially relate to pain outcomes in non-Hispanic Black and non-Hispanic white adults with knee osteoarthritis, which suggests we should be doing intra-group studies rather than comparing groups a bit more frequently than we have in the past. Another thing that we've been interested in for a number of years is whether individuals from different racial and ethnic groups experience pain differently in the laboratory. So when we induce the pain, as opposed to studying the pain that somebody brings with them to the lab using quantitative sensory testing. And more than 10 years ago now, Bridget Rahim-Williams, a postdoc in our lab at the time, did a meta-analysis of the then existing evidence for differences in experimental pain responses between non-Hispanic Black and non-Hispanic white adults. And you can see here there are a lot of different pain measures, there are a lot of different pain stimuli, and pretty well across the board, these studies, and these are almost entirely studies of healthy adults. These studies showed that non-Hispanic Black individuals report lower pain thresholds and tolerances and higher pain ratings than their non-Hispanic white counterparts. There's one exception here from 2 studies of ischemic pain threshold, but the others are all in the direction of greater pain sensitivity, if you will, in non-Hispanic Black individuals, and the effect sizes are generally moderate to large. We've looked at these kinds of measures in our sample of individuals with knee osteoarthritis, and here we're doing heat and pressure pain testing, both on the affected knee as well as in other unaffected parts of the body. These are normalized data, they're z-scores, so the mean for the entire sample is 0. As the bars go up, that means lower sensitivity, that is higher pain threshold and tolerance. As the bars go down, that means lower pain threshold and tolerance or higher pain sensitivity. And in this slide, you see that no matter how or where we hurt people, our non-Hispanic Black participants are reporting more pain than our non-Hispanic white participants. If we then move to more dynamic measures of pain sensitivity, this is temporal summation of pain with repeated stimulation at the same intensity due to transient central pain amplification, there's an increase in the percept of pain, and that's that increase in slope, right? These 5 trials are all of equal intensity, but they get more painful because we're amplifying them centrally due to the repeated stimulation. And you see here that our non-Hispanic Black individuals both report higher pain overall, but also have a steeper slope, suggesting that that summation, that amplification is greater among our non-Hispanic Black individuals. And then with temporal summation of mechanical pain, it's a fairly similar procedure. We poke people 1 time and say, how painful was that? We then poke them 10 times and ask how painful that was. And the difference between the painfulness of 10 trials versus 1 trial is thought to be a measure of temporal summation of mechanical pain. Again, our non-Hispanic Black individuals, whether we're poking their affected knee or their unaffected hand, they're reporting both more pain and more summation of this painful experience. And so this begins to give us a picture that there may be a pain modulatory imbalance, right? If we think of healthy perception of pain as a balance between amplification of pain so that we can feel pain when we need to versus inhibition of pain so that we can control pain and have it not interfere greatly in our lives, there's an indication here that among our non-Hispanic Black participants, we're getting more pain facilitation and less pain inhibition, which can create an unhealthy imbalance. Another factor we certainly need to consider, and if we hearken back to the findings, that it's not necessarily that, let's say, African Americans have more frequent chronic pain, it's that they have more severe chronic pain. One culprit here might be that once you have chronic pain, we don't treat people equally. And inadequate treatment could create this pattern of findings that individuals, once pain is established, get worse. Whereas other individuals who get adequate treatment get better. And the health disparities framework here does call for research on the healthcare system. Carmen Green has recently commented on this, saying racial disparities in health and healthcare are well described, even when matched by socioeconomic insurance status. Embedded in the disproportionate morbidity and mortality rates are historical and continuing practices in the United States yielding low-quality health care and poor health outcomes for minority patients. And this indeed appears to be the case. This is emergency department pain management in the context of acute pain. Black patients were 36% less likely to receive any analgesia. Hispanic patients, 30% less likely to receive analgesia compared to white patients. So we're providing unequal care to patients. This also is true in the context of chronic pain, where this systematic narrative review concluded that there's a substantial amount of evidence for racial and ethnic differences in the treatment of chronic pain and in the long-term monitoring of opioid use. This may be, at least in part, due to biases that many of us hold around race. These are data from virtual human studies where they present a case and ask people questions about their pain stereotypes. In this particular study, both white and Black college students reported that the typical Black person is less pain sensitive than the typical white person. If we hold such biases in the healthcare system, this might justify us giving less medication to Black individuals. This PNAS study, you may have seen, this got a lot of attention about 10 years ago when it came out. And it did 2 things. One is it asked medical students and residents to answer some questions about Black individuals. And you can see some of the example questions here. Blacks' nerve endings are less sensitive than whites. Whites have larger brains than Blacks. And so Surprisingly, medical professionals in training endorsed many of these false beliefs, and what's more, the extent to which you endorsed these false beliefs predicted how you would prescribe pain treatment in a vignette scenario. So those individuals who endorsed more of these inaccurate beliefs about Black individuals were more likely to undertreat the hypothetical pain of a case they were presented with. Okay? Another factor that is worth considering in the context of provision of health care to people from different racial and ethnic groups is the concordance or discordance of physician and patient race. And as you might imagine in the United States, when a Black individual seeks care, they are most often discordant in race with their provider because there just aren't that many Black healthcare providers. This has been looked at in other areas of literature, not so much in the pain space. Liz Lowson, then at Miami, now at Penn State University, did sort of an analog study where she used laboratory-induced pain as the painful procedure, and she manipulated the concordance of the physician and the patient here, simulated patient race. And what she found was that concordance between the hypothetical clinician and patient in this analog study reduced pain and pain-induced physiological arousal for Black patients. That is, when the medical procedure, in this instance experimental pain, was delivered by a Black physician, the Black participant reported less pain. There was no such effect of racial concordance in the white participants in this study. So this suggests that physician concordance in the context of pain care might be something we want to think about in future work. And so that's been a fairly rapid summary of some of the work that's been done on race, ethnicity, and pain. Race and ethnicity are associated with pain severity and pain-related disability. They are also associated with laboratory-based measures of pain processing. Again, I'll make the point that race and ethnicity are not causal factors, rather proxies for multiple systemic barriers and adverse environmental exposures that indeed get under the skin and can alter pain responses. Race-related biases clearly drive undertreatment of pain in minoritized patients in many studies. And we need additional research within different disadvantaged and minoritized populations to understand the unique factors that are contributing to pain within these groups. And with that, I'll acknowledge my many colleagues at Price at the University of Florida, as well as our funding agencies, and I'll thank you for your attention.